Physiology. The first topic is the cardiac output variables. The cardiac output is determined by a few variables, one of which is the stroke volume or the heart rate. Another one is the contractility, and the third one is the preload, which is also known as left ventricular end diastolic pressure, and the fourth one is the afterload, which is also known as the mean arterial pressure. So the first one, the stroke volume, it is affected by contractility, afterload and preload. How? The stroke volume increases with increase in contractility, which is very obvious that increase in anxiety or sympathetic stimulation of the heart increases the contractility of the heart, that eventually results in increased stroke volume. Similarly, if the preload is increased, so more blood is coming into the right atrium, which in response pushes out more blood out of the heart into the systemic circulation, so the stroke volume is increased. Now if we increase the afterload, then the heart has to do more work against increased systemic pressure. That's why the stroke volume will be reduced. So the stroke volume depends on these three factors: the contractility, which increases the stroke volume, the preload also increases the stroke volume, and the afterload decreases the stroke volume. The second factor, the contractility, it is increased with increase in sympathetic stimulation. For example, catecholamines, it increases the sympathetic stimulation. With increase in sympathetic stimulation, what happens is the catecholamines acts on the beta 1 receptors of the heart. It activates protein kinase A, and it causes calcium induced calcium release. What does it mean? That the calcium ion is necessary for the release of calcium from the sarcoplasmic reticulum of the cells, and that increased calcium concentration results in cardiac contractility. So for example, if we want to increase the contractility, what we can do is that we can increase sympathetic stimulation or increase in catecholamines. If we want to decrease contractility, then we can use beta blockers. Beta blockers will decrease the activation of this pathway, and the contractility will be decreased. Similarly, in the heart failure with systolic dysfunction, what happens is contractility is reduced. Why? Because the myocytes are not functional and it cannot contract with that force. Similarly, acidosis and hypoxia or hypercapnia also decreases the contractility, and the calcium channel blockers, because when calcium is necessary for the contraction of the cardiac myocytes, when we decrease the calcium concentration, that will results in decreased contractility. If a patient is given digoxin, so what is the mechanism of action of digoxin? Normally what happens is that there is a channel in the membrane of the cell called sodium potassium ATPases. That sodium potassium ATPases, it pumps 3 sodium out of the cell, and 2 potassium are pumped into the cell. So normally it happens this way. And then again there is another exchanger on the membrane which is called the sodium calcium exchanger. Once the sodium potassium ATPases removes 3 sodium out of the cell, then the intracellular calcium concentration is decreased. That low calcium concentration, it is used by this channel to remove this calcium out of the cell, and that's how it decreases the contractility. Normally it happens this way, but when you administer digoxin to a patient, it blocks the sodium potassium ATPases. When sodium potassium ATPases no longer works, then the intracellular sodium concentration remains increased. When it remains increased, then this channel, the sodium calcium channel, cannot work because the intracellular calcium is already increased, so it cannot pump sodium into the cell and remove potassium out of the cell because intracellular concentration is already more, so it cannot bring more sodium into the cell. That's why this exchanger is not working. So when this exchanger is not working, calcium is trapped into the cell. When calcium is trapped into the cell, it increases the contractility. So digoxin, it is used for a failing heart. When it is not able to contract properly, we administer it to the patient. It increases intracellular calcium concentration in this way and increases the contractility. The third variable is the left ventricular end diastolic pressure or end diastolic volume. It is also known as the preload. So the preload, it depends on two factors. The preload, it depends on the venous tone and the circulating volume. How? If we want to increase the preload, we have to increase the fluid infusion. It will increase the preload. Similarly, if we increase the venous tone, then the blood from the veins will be pumped into the heart. It will increase the preload and eventually it will increase the cardiac output. Similarly, if we want to decrease the preload, so we have to remove the blood or the fluids from the circulation. That happens during decrease in preload happens during hemorrhage, during dehydration, and that's how it decreases the cardiac output. Similarly, the vasodilators, it decreases the venous tone and it decreases the preload. The afterload is also approximated by the mean arterial pressure. So when the mean arterial pressure or the afterload is increased, the heart has to do more work against that pressure, so the cardiac output will be decreased. So it has an inverse relation with the cardiac output. Here the arterial dilators, for example hydralazine, it decreases the afterload and increases the cardiac output. One thing you have to remember that angiotensin converting enzyme inhibitors and ARBs, these decrease both the preload and afterload. This is very important point for your MCQs. Now in chronic hypertension, what happens is there is the left ventricular hypertrophy. Why? Because heart is, every time it beats, it has to do more work against that increased pressure. And how the increased systemic blood pressure results in increased wall thickness, it is shown by the Laplace law. You can see here the Laplace law. According to this law, if we wants to if there is pressure is increased, so the systemic BP is increased. If we want to keep this wall tension constant, we must increase the wall thickness in order for this to be constant. That results in left ventricular hypertrophy. So left ventricular hypertrophy can be explained by this law. One topic which is given separately here is cardiac oxygen demand. The cardiac oxygen demand is increased by increase in contractility, increase in afterload, and increase in the heart rate. So when contractility increase, it is very obvious that the cardiac oxygen demand will decrease. Similarly, the afterload and the heart rate. And when the diameter increases, the heart has to use more oxygen to overcome that wall tension and provide blood to the body. So the oxygen demand increases with all these factors. Then there are a few equations that the stroke volume, it is the difference between the end diastolic volume and the end systolic volume. What does it mean? That at the end of contraction, at the end of systole, there is a volume left in the ventricle which is known as end systolic volume, and at the end of diastole, when the ventricle is completely filled, there is a volume left in the ventricle which is called end diastolic volume. So what is the stroke volume? The stroke volume is the difference between these two, that at the end of the diastole the volume accumulates, and at the end of systole the certain volume accumulates. So how much is the volume that is provided during systole is the stroke volume, and it is the difference between these two volumes. Now, what is ejection fraction? Ejection fraction is the amount of that stroke volume divided by end diastolic volume. What does it mean? That how it shows us how good a heart is at contraction. Because if for example there are two hearts, and out of 120 ml, one is providing 60 ml to the body and the other is providing 80 ml to the body. So which one is better? Ejection fraction of this heart is better. That's because out of the same end diastolic volume, one is providing more stroke volume to the heart. So it is the index of ventricular contractility. If there is systolic heart failure, then the ejection fraction will be reduced, even though the end diastolic volume for both the hearts will be the same. So this is basically the word itself explains ejection fraction. So this is that fraction of the end diastolic volume which the heart is able to provide to the body. Normally it is 55 to 60. So if it decreases, we say that the heart is failing. Then there is the cardiac output. The cardiac output is stroke volume into the heart rate. So this equation, if we look at this, it shows that if we increase the heart rate, the cardiac output will also be increased. If the stroke volume is increased, and the cardiac output will be increased. But all these happen within the physiologic limits. If during exercise the heart rate is increased way too much, then the heart does not get a chance to be filled with blood. When it is not getting a chance to be filled with blood, then the cardiac output is not increasing to that extent. So all these equations work when you study them in physiologic limits. Similarly, in some arrhythmias, the heart rate is increased way too much, but it does not increase the cardiac output. For example, in atrial fibrillation, the heart rate is too much, but still the body is not receiving the cardiac output because the body is in shock. And so this equation is in physiologic limits, not pathologic. So in early stages of exercise, cardiac output is maintained by both the increase in heart rate and stroke volume. Eventually the heart rate, the stroke volume plateaus, and the heart rate is only increased, and that maintains the increased cardiac output. Then the heart gets its blood supply during diastole. So whenever the heart rate is increased, it is the diastolic phase that is shortened. And with too much increase in the heart rate, the diastolic filling time is decreased. That's why eventually the stroke volume and the cardiac output is reduced, which is contrary as shown in the equation. And there is a fixed principle. It shows that how much is the oxygen consumption and cardiac output. In this way we can calculate by the rate of oxygen consumption divided by arterial oxygen minus venous oxygen content. Then there is the pulse pressure. The pulse pressure is directly proportional to stroke volume and inversely proportional to arterial compliance. So the pulse pressure increases in hyperthyroidism, aortic regurg. We will study that. There is a graph later which we will study, in which pulse pressure is increased in aortic regurg and aortic stiffness and obstructive sleep apnea, anemia. Also pulse pressure is increased in exercise. Also transiently pulse pressure is increased, and it decreases in aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. So what is pulse pressure? Pulse pressure is the difference of the systolic and diastolic blood pressure. For example, systolic BP is 120 and diastolic is 80. So the difference between these two will give us pulse pressure. Now, what is mean arterial pressure? So throughout the circulation there is a certain pressure within the veins, which is determined by that venous tone, that is known as the mean arterial pressure. So it is more towards the diastolic than the systolic. It is more near to the diastolic blood pressure than the systolic. That's why when we want to take mean, we take 2/3 of the diastolic and 1/3 of the systolic BP. So 2/3, and there are questions in the U word where you have to calculate this mean arterial pressure, and the diastolic blood pressure and the systolic are given. So just use this equation, 2/3 of the diastolic and 1/3 of the systolic. So it is more towards the diastolic side than the systolic. And you can also calculate it by this equation, cardiac output into total peripheral resistance. Now we have an important graph known as the Starling curve. We know that according to the Frank-Starling equation, if we increase the preload into the heart, that increases the stretch on the myocardium. That increase in the stretch on myocardium. So when it during diastole, when it fills with blood, the stretch on myocardium is more if the preload is more. So during diastole, it will force this blood out into the systemic circulation with much force, because there was much more stretch on the myocardium. That will increase the cardiac output and the stroke volume. So more the preload, with much force the heart is contracting, and it tries to get rid of all the blood that it received during the filling phase. That's why according to the Frank-Starling equation, ventricular end diastolic volume or preload is directly proportional to the stroke volume. When we increase the ventricular end diastolic volume, the stroke volume also increases. So this is the cardiac output or the stroke volume, and this is the end diastolic volume. So this graph basically correlates these two. You can see that this is normal, that the force of contraction is directly proportional to the end diastolic length of the cardiac muscle. So basically it is that stretch on the myocardium. So when you increase contractility with catecholamines or positive inotropes, what will happen? It will move this graph towards the left. What does it mean? That for the same amount of ventricular end diastolic volume, it is giving much more stroke volume or cardiac output. So it moves the graph towards the left. At the same time, when we give beta blockers, calcium channel blockers, or there is a failing heart, so the myocytes are diseased, in that case the heart is not able to force all the blood into the systemic circulation which it received during diastole, because you decreased the cardiac contractility by calcium channel blockers, or you decreased it by when the heart is failing. So the graph moves down, graph moves to the right. It means that the end diastolic volume is increasing, but due to failing heart, the stroke volume is not increasing that much. So that's how these are related. Now there is another graph called the vascular function curve. So we can correlate these two graphs. There is a cardiac output graph, and then there is a vascular function curve. So we have to correlate both of these. In the vascular function curve, what happens is that we check the relationship between the right atrial pressure and the venous return. The right atrial pressure and the venous return. So the point at which the right atrial pressure, this graph intersects at x-axis, it is known as mean systemic filling pressure. And mean systemic filling pressure, if you see on this graph, when it reaches the right atrial pressure on x-axis, the cardiac output here is 0. What does it mean? That basically the cardiac output is determined by the difference of mean systemic filling pressure and right atrial pressure. This difference determines how much will be the cardiac output. So we have to correlate these two graphs. First of all, just independently, if we look at the vascular function curve, so when we are increasing the right atrial pressure and we correlate it with the venous return, it gives us a graph like this. This is the cardiac operating point. So we have just combined the two graphs. One is the vascular function curve, and the other is the cardiac output curve. These two. And the point at which these two intersect is called the cardiac operating point. So if we look at this graph, this first graph, the changes in contractility, it means that if we give a positive inotropic agent, it will move the graph, it will shift the graph upward and to the left. Why? It means that at the same right atrial pressure, it is giving more cardiac output. Why? Because you increase the contraction power of the heart by giving a positive inotropic agent like catecholamines, dobutamine, digoxin, or exercise. So increase in whenever you give a positive inotropic agent, what will happen? The graph will move upward and to the left. Similarly, if you give the opposite, the negative inotropic agent, for example, you do parasympathetic stimulation, or there is a failing heart failure with reduced ejection fraction, what will happen? That the graph will move to the left and downward. It means at the same right atrial pressure, the cardiac output is reduced. So just remember this. The second graph shows that the venous return, when it is increased or venous tone is increased, then the graph moves towards the left. But there is a difference between the first graph and the second graph. In the first graph, at the same right atrial pressure, the cardiac output was increasing. But here, when the cardiac output increases, it increases with increase in the right atrial pressure as well. Why is this happening? Because you are infusing volume, you are giving IV fluids, so that IV fluid increases the preload, and increase in that preload increases the right atrial pressure because more blood is being given to the right atrium. So the graph will move towards the left. It will, so with increase in volume or venous tone, both the right atrial pressure and the cardiac output increase, while with the increase in a positive inotropic agent, at the same right atrial pressure, the cardiac output is increased. So this is the difference between these two graphs. Similarly, if you increase the total peripheral resistance. If you increase the total peripheral resistance, then what happens? When the total peripheral resistance is increased, then the cardiac output is decreased. And when you decrease the total peripheral resistance, the opposite happens, but the right atrial pressure remains the same. So in practical life, it does not happen in like the individual changes does not happen in the same patient. For example, if there is a patient who has a failing heart, so there is negative inotrophy, the contractility power of the heart is also decreased. At the same time, there is fluid retention, so that fluid retention will increase the preload, and that preload will again shift the curve to the right, but at an expense of increase in the right atrial pressure. So in the same patient, the two phenomena are happening. So just remember these examples with these graphs and how we can correlate the cardiac output graph with the vascular function graph, and what is the cardiac operating point, and how the graph moves in response to increase or decrease in various variables. Now there are a few equations which are important. There is the blood flow. So the blood flow is equal to velocity into cross-sectional area. So velocity into cross-sectional area, it means that the velocity is equal to blood flow into cross-sectional area. What does it mean? It means that in the systemic circulation, the largest cross-sectional area is of the capillaries. So the slowest flow will be in the capillaries, and that is important for gaseous exchange and for the nutrients. So for the blood to flow slowly in the capillaries, it is important that they have the increased total cross-sectional area. It is explained by this equation. At the same time, you remember another equation that you remember Ohm's law. V equal to IR. So you can remember that R is equal to V by I. So the driving force, it was the voltage and there was the current in the denominator. So you can remember an equation similar to this, that resistance equal to V, a driving force equal to change in pressure, and I is the flow. So here there was the current flow, the electrons flow, and now here is the blood flow by Q. You can also remember that there is an equation called Poiseuille's equation, which can be written as 8 viscosity into length divided by pi r raised to the power 4. So this equation shows that the resistance, it is inversely proportional to the fourth power of the radius. So when we decrease the radius, the resistance is increased much more. The fourth power here is important. That's why arterioles account for the maximum total peripheral resistance, and the veins provide the unstressed volume. So they are basically storage for the blood. And when we increase the viscosity, so there is another equation you also have to remember, that is the Reynolds number. The Reynolds number is the equation is like this: dV by viscosity. Basically this equation is used to determine the turbulent flow of the blood. Blood flows in two ways. One is the laminar and the other is the turbulent. The turbulent flow is like zigzag, it strikes with the walls. So to know that how much the blood will flow, whether it will flow with a laminar flow or a turbulent flow, this equation helps us. For example, the viscosity of the blood is increased. With increase in viscosity, what happens is, when you increase the viscosity of the blood, the Reynolds number is reduced, so there is a more laminar flow. When there is anemia, so there is a more turbulent flow, and similarly it is related with all these variables. Then there is a series or a parallel. So in the series, the resistance add up, so it increases, and while in parallel it decreases, and our body circulation is the parallel one. So we will just compare that what happens in series and what happens in parallel. The resistance increases, the total resistance is more than the individual resistance. The resistance increases. Similarly, the flow remains the same in series. The blood flow to every organ remains the same in series, while the pressure is decreased. In parallel circulation, the resistance is decreased. It is less than that of the individual resistance. The flow is decreased while the pressure remains the same. To every organ, the pressure flows with the same pressure to every organ. So our body circulation is an example of the parallel one. Now, very important part of this cardiac physiology module are these two graphs. This page is very, very important. We have to take some time for this. The pressure volume loop. How the pressure volume loop correlates the left ventricular pressure with that of the left ventricular volume. So here you can see, let me explain it on a separate page, that the pressure volume loop, how it correlates the left ventricular pressure with that of the left ventricular volume. So there are four phases of this diagram. The first phase is isovolumetric contraction. Isovolumetric contraction means that the ventricle contracts while the mitral valve is closed. So what happens is, during isovolumetric contraction, when the ventricle contracts, this is the heart. When the ventricle contracts, here is the contraction phase of this ventricle. What happens is that the pressure rises. The pressure rises, but the volume does not change. Why? Because the mitral valve is closed here, and similarly the aortic valve is also closed. So in isovolumetric contraction, the ventricle contracts as a whole. So the pressure rises, but the volume does not change. When the pressure keep on rising, it gets rise so much that it forces open the aortic valve to open. So the aortic valve open here, and here the mitral valve was closed. So this is a phase of isovolumetric contraction. Now what will happen after contraction? The blood has to eject through this open aortic valve into the aorta. So here it is a phase of the second phase is systolic ejection phase. Systolic ejection phase. What happens is the aortic valve is open and the blood is leaving the heart. So the volume in the heart is reducing. You can see that the volume is reduced. The volume is reduced. Eventually, the aortic valve closes. The aortic valve closes, and the third phase starts. The third phase is the isovolumetric relaxation. What happens is that the ventricle relaxes as a closed chamber. What does it mean? That the aortic valve is closed here, and similarly when it relaxes as a whole, so the pressure just decreases. The pressure decreases, but the volume does not change. It remains the same, just the pressure decreases until it reaches a point that the mitral valve opens, and again the left ventricle starts filling. So first of all there is reduced filling, and then there is rapid filling, and then there is reduced filling. So with the filling, what happens? The volume increases because the left ventricle is filling. So that's how this whole pressure volume loop operates. So here the mitral valve was closed. So the closing of the mitral valve produced which sound? S1, the first heart sound. Similarly, the closing of the aortic valve produces, which was here, it produces which sound? It produces the second heart sound, S2. Now let's look at the diagram here. So here is end systolic volume and end diastolic volume, and the width of this graph, it represents the stroke volume. As we have studied earlier, that end diastolic volume minus end systolic volume gives us the stroke volume. So the width, the more the width, the more the stroke volume, and less the width, so less the stroke volume. So this is the first phase, that isovolumetric contraction, the period between the mitral valve closing and aortic valve open. What happens? The isovolumetric contraction happens, that the ventricle contracts as a whole chamber. It increases the pressure, but the volume does not change, and it is a phase of maximum oxygen consumption until the pressure rises so much that it forces open the aortic valve. And what will happen after that? What will happen? The blood will leave the left ventricle. When the blood will leave the left ventricle, the volume is reduced. You can see that it is pointed in this direction means the volume is reducing, and then again the volume reduced so much that the aortic valve has to close, and the closing produces a second heart sound. And then what happens is that the pressure is reducing but the volume is not changing. It means it is all isovolumetric relaxation. The ventricle is relaxing as a closed chamber, and then there is a rapid filling, and the last phase is the reduced filling. That's how this loop operates. But we have to correlate it with a few things. The first thing is how this loop changes in response with the increase in the preload. When the preload increases, you see this green line that the width of the pressure volume loop increases. The width increases. What does it mean? That this we already said that the stroke volume is determined by the width of this pressure volume loop. Increase in preload increases the width of this graph, and it is very obvious that increase in preload increases the stroke volume. We already studied that. And it also increases the end diastolic volume, because with increasing preload the heart is filling more, so end diastolic volume is more, and as a result when it pumps that blood out of the heart, so the stroke volume is also more. So increase in the preload increases just the width of the graph. Similarly, increase in the afterload increases the height of the graph, but the width is reduced. What does it mean? It means that during the isovolumetric contraction phase, the pressure is increased too much. Why? Because the afterload is increased, so the heart has to do a lot of work against that increased pressure to open the aortic pressure. The afterload is more, so the heart has to do more work. Even with that more work, it is not able to increase the stroke volume, so the stroke volume is reduced, which is shown by the decreased width of this graph, and the end systolic volume is more. Why? Because at the end of the systole still some blood is left in the heart, which the heart is not able to get rid of even with increased work. So increase in afterload increases aortic pressure, decreases stroke volume, and increases end systolic pressure. If you look at the contractility, how it changes with the contractility, so the contractility increases both the width and the height. How is that important? When the contractility increases, the stroke volume increases. That is very obvious. Similarly, the ejection fraction increases. This point is important. It is due to this point that the width and the height both increases. When the contractility increases with a positive inotropic agent or exercise or in some stuff like that, so what happens is for the same amount of the end systolic pressure, it is producing more stroke volume. That eventually results in increased ejection fraction, so the end systolic volume is reduced. It means that the heart is doing a better work. It is a better heart. It is very better at contraction. That's why it is getting rid of more blood. So that's why the end systolic volume is reduced. So increase in contractility will cause increase in both the width, which will increase the stroke volume, and the height. So both of it is increased. It is because of the increase in the ejection fraction. Now the next diagram is also very important. So to understand this diagram, this is called the Wrigley's diagram. It correlates with the different points in the heart chambers with each other. So first of all, we will start with the electrocardiogram. Let me explain it separately. In the electrocardiogram, what happens is that there is a P wave, there is a PR interval, then there is a QRS complex, and there is a T wave. Sometimes there is a U wave as well. So the P wave, it corresponds to the atrial depolarization, and we know that the electrical activity of the heart is preceded by which activity? By the mechanical activity. So when atrial depolarization happens, after that atrial contraction will happen, and when the QRS it corresponds towards the ventricular depolarization. So after ventricular depolarization, it is followed by the mechanical activity, which is ventricular contraction or ventricular systole, and the T wave represents the ventricular repolarization. Here there is no wave for the atrial repolarization because it is masked by the QRS complex, and the T wave shows the ventricular repolarization. So the ventricular repolarization, it is followed by the ventricular diastole. So if we correlate this ECG with the Regles diagram, first thing is the atrial depolarizations, which is followed by the atrial systole, and then there is the QRS complex. It is followed by the ventricular contraction. So you see that a little earlier the electrical activity happens, and after a little late the mechanical activity happens. So electrical activity is usually followed by the mechanical activity of the heart, and similarly the T wave, so it is followed by the reduced ejection, or the ventricular diastole follows. So this phase is the ventricular systole, and this is the ventricular diastole. The ventricular diastole is the phase which changes with increase in heart rate. With increase in heart rate, the diastolic filling time is reduced, while the systolic time usually stays the same. Similarly, that's how the QRS is related to all these phases. And if we look at the heart sounds, so the first heart sound, the heart sounds are usually produced by the closing of the valves, not by the opening of the valve. So S1, it is at the start of the isovolumetric contraction. At the start of the isovolumetric contraction, we studied that there is S1 because the mitral valve, it closes, so it produces S1. So you can relate it with the pressure volume loop as well. Similarly, the S2, it is produced by the aortic valve closing, and it is produced when the aortic valve closes at the start of the isovolumetric relaxation. So that's how. Now, when is the S4 produced? S4 is produced, it is a pathologic sound when the atria contracts against the stiffened ventricles. When the atria contracts against the hard ventricles, so it produces S1. So when atrial systole occurs here, so that's why S4 is related here. And S3 is a sound that is produced by the rapid ventricular filling. It is produced by the rapid ventricular filling. It is normal in the children and younger adults, but in the older adults it is usually pathological. It shows that there is a volume overload states. So volume overload states that occurs during the rapid filling. If during a rapid filling there is S3, then that is pathological in older adults and in the volume overload states. So that's how the heart sounds are related. Now we have to study this venous jugular venous pressure, how it is related. So the jugular venous pressure, let me explain it separately. The jugular venous pressure, it is also known as jugular venous pressure or right atrial pressure because the right atrium and the venous system are connected to each other. So the first wave is the A wave. The A wave, how it is produced? It is produced by the atrial contraction. When the atria contracts, a little increase in pressure occurs, and that is shown by the A wave. It is absent in the atrial fibrillation because the atria is not able to contract properly in the atrial fibrillation. So the A wave and the JVP is absent. Then after the atrial contraction, what happens? When the atria contracts, it pushes the blood into the ventricles, and then the ventricular contraction occurs. So the right ventricle contracts, and that right ventricle contraction, it causes what? It pushes the tricuspid valve back into the right atrium, and that pushing of the tricuspid valve into the right atrium, it causes a C wave. So increase in pressure occurs here, and then after that the atria relaxes because here the atrial systole occurs and the right ventricle contracts. Now what will happen? The atria will relax. So when the atria relax, the tricuspid valve moves down and the pressure is released. So it moves downward, and the downward displacement of the closed tricuspid valve during the right ventricular ejection phase, it causes an X descent. What will happen after the atrial relaxation? Slowly blood will again fill into the right atrium. So when the blood will again fill into the right atrium, the right atrial pressure will slowly rise, and because the tricuspid valve here is closed, so against a closed valve, when the pressure rises, when the blood fills and the pressure rises, it results in a V wave. And then again what happens is that the right atrium again empties into the right atrium empties into the right ventricle, and a Y descent happens. So that is how it proceeds. First is the atrial contraction, and then is the right ventricular contraction, the C wave. Then is the X descent, that is caused by the right atrial relaxation and downward displacement of the tricuspid valve into the right ventricle. And then is the V wave due to slow filling of the right atrium. And then is the Y descent. The Y descent is because of the right atrium emptying into the right ventricle. Now, in certain conditions, we will discuss, in certain pathological conditions, these waves, they help us to identify those conditions. For example, if there are large A waves, if these A waves are large like this, it happens in tricuspid stenosis. Why? Because the right atrial contraction is shown by this A wave. So when the tricuspid valve is stenosed, the right atrium has to do a lot of work against that stenosed valve to make it open, to push it open. So the right atrial, this A wave will increase, it will be large A wave. Then there are the Cannon A waves. The Cannon A waves are also large A waves, but in the tricuspid stenosis, this A wave is fixed. In every JVP, you will see this large A wave. But in the Cannon A wave, somewhere the A waves will be increased and somewhere you will see small A wave. Then again, this way it will go on. Why? It happens in the AV dissociation, like in the third heart block. In the third heart block, what happens is the atria contracts at its own phase and the ventricle contracts at its own phase. So somewhere during the ventricular contraction, the atria contracts, and that way it has to generate higher pressure. In others, it contracts while the atria is relaxing, so it does not has to produce a lot of pressure. So some waves are big and some are smaller, known as Cannon A waves. The third kind of waves is when they are absent. A waves are completely absent, and I already told you that it happens in atrial fibrillation because the atria is not able to contract properly. So these are some pathological conditions. Now let's go back to the diagram. So the A wave, you see, you can correlate with the atrial systole. The C wave happens during isovolumetric contraction. How? The C wave was happening during which phase? The right ventricular contraction. So it is the isovolumetric contraction. You can also correlate it with the ventricular volume, that during isovolumetric contraction the volume just rapidly decreases. The volume after after the isovolumetric contraction, there is a rapid ejection phase. During that rapid ejection phase, the volume is drastically decreased in the left ventricle, which is shown by this graph here. And in the X descent, it is the atrial relaxation. It occurs during, so the atrial relaxation, it corresponds to which phase in the cardiac cycle? To the rapid ejection phase. The V phase, it responds here. So you can correlate all parts of the diagram here. Now if we look at the left ventricle pressure, the left atrial pressure, you can also see the left atrial pressure is similar to the right atrial pressure, just it is on a different side, and the pressure overall is a bit higher. We will study a diagram that how much is the pressure in each chamber. So the pressure is just a bit more but the waveform is exactly the similar. Now if we look at the aortic pressure, so in the aortic pressure, the pressure rises like this in the isovolumetric contraction until the aortic valve opens, and then it decreases in the reduced ejection fraction in the isovolumetric relaxation, and at the start of the isovolumetric contraction the aortic valve closes, and that results in a dichrotic notch. Why? Because when the aortic pressure was rising, because the left ventricular was ejecting, this when it was about to the aortic pressure was the left ventricular pressure was about to decrease, the valve just leaks a little bit of blood, and after that it closes. So that results in a little dip in the aortic pressure after it closes. That results in a dichrotic notch, which is lost in certain diseases, which we'll study later. So that's how all parts of this diagram you can correlate. Now if we look at these uh, pathologies, so look at the aortic stenosis. What happens at the aortic stenosis? Aortic stenosis. In aortic stenosis, what happens is that the height of this graph is increased. What does it show? It shows that during the phase of the isovolumetric contraction, the left ventricle has to uh, generate higher pressures in order for the aortic valve to open. That will results in increased left ventricular pressure, and similarly, the end systolic volume is increased. Why? Because the aortic valve is stiff, and even if the left ventricle generates higher pressure, still some blood is left at the end of the contraction in the left ventricle. That increases the end systolic volume. So the height of the graph is increased in aortic stenosis. Similarly, the stroke volume is reduced. Why? Because end systolic volume is reduced. It is not able to get rid of all the blood because of the stenosed valve. So the stroke volume is reduced, which is shown by the decreased width of this graph, and increased height shows increased left ventricular pressure, and it results in left ventricular hypertrophy and decreased ventricular compliance. Now if we look at the this part of the diagram, so it shows that this is the aortic pressure and this is the left ventricular pressure. So the left ventricular pressure is more than the aortic pressure. If you look at the aortic regurg, what happens is the aortic valve here is leaky. It is trickling some of the blood back into the left ventricle. That increases the end diastolic volume. Even at the end of diastole, there is some blood left because the valve is leaky and it is increasing the volume of the left ventricle. So when the next beat will happen, the stroke volume will be increased. The heart will try to get rid of that extra volume, that will increase the stroke volume. And here the dichrotic notch, which we studied in the last diagram, is lost. Why? Because the dichrotic notch happens due to the rapid closing of that aortic valve when the left ventricular pressure decreases from that of the aortic pressure. But here it is not able to close because it is leaky, it is regurgent valve, so the dichrotic notch is lost, and it also results in a large pulse pressure. Similarly, what happens in the mitral stenosis is, in the mitral stenosis, if you look at the width of the graph, it is reduced, which you can correlate that the stroke volume is reduced. Why? Because the mitral valve is stenosed. When the mitral valve is stenosed, then the blood is not able to pass through the stenotic valve from the left atrium, so the left atrial pressure is rising. Similarly, it is not able to provide that blood to the left ventricle, so the end diastolic volume is reduced because of the impaired ventricular filling, and the end systolic volume is also reduced. So you look at the graph that the width is reduced, and it shows that the systolic stroke volume is reduced, and similarly the end diastolic volume is also reduced because it is not able to fill the left ventricle through that stenosed valve. You can see that here, normally this part of the graph which shows the left atrial pressure, it is here, it is like a little lower in pressure, but here it is increased because of the stenosed valve. The left atrial pressure is more than the left ventricular pressure. If you look at the mitral regurgitation, what happens is the mitral valve is leaky, it is regurgent, so the end systolic volume is reduced due to decreased resistance and increased regurgitation in the left atrium during systole. And similarly, here the isovolumetric contraction is disrupted because the end diastolic volume is increased. Why? Because the valve is leaky and the left atrial pressure rises, and it increases the ventricular filling time. So it increases the end diastolic volume as well. When that volume increases, again the stroke volume is also increased, which is shown by the increased width of this graph. So those were all the pathological conditions related to the pressure volume loops. Now if we study the cardiac heart sounds, so the first heart sound and the second heart sound, the first heart sound does not split. Even it is the first heart sound comprises of two components, the M1 and the T1. M or T. Usually the mitral valve closes before the tricuspid, but they happen so quickly and so close to each other that we say that the first heart sound does not split and the second heart sound does split. So how the second heart sound splits? What happens is, one is the physiologic splitting. During inspiration, what happens is that there is a decrease in the intrathoracic pressure. Whenever the intrathoracic pressure decreases, what does it mean? It means that the heart sucks the blood inside. So when it sucks the blood, so it increases that venous return. That will increase the right ventricular filling and will increase the stroke volume. And the opposite happens in Valsalva. In Valsalva, what happens is whenever the pressure rises, when the pressure rises, then the venous return will decrease. So you have to remember this for remembering the splitting of the physiologic splitting, that during inspiration, a drop in thoracic pressure happens, and that drop in thoracic pressure, it sucks the blood into the heart and it increases the venous return. So whenever the venous return increases, what will happen? That blood will eventually pour into the right ventricle and the right ventricle volume will be increased. And the right sided valve will close later. Why? Because the volume on the right side is more, so the pulmonic valve will take a little more time to close than the aortic valve. That will delay the closing of the pulmonic valve. So you see here that the pulmonic valve, the closing of it is delayed during inspiration. Why? Because the venous return is more during inspiration and the pulmonic valve is taking a little longer to close. That's why the P2 component of the second heart sound is delayed. And this is normal. Normally it happens this way. Then there is a wide splitting. Wide splitting means that it is the same splitting of the second heart sound during inspiration, but it is exaggerated. So an exaggeration of the normal splitting. It is seen in the right bundle branch block or pulmonic stenosis or pulmonary hypertension. Why? It is seen in these conditions. What happens is, for example, if in the pulmonic valve is stenosed, so it will take longer time for the right ventricle to open that stenosed valve. That will result in P2 being late, but a little late than the normal delay. So this is an abnormally exaggerated delay. It's known as wide splitting. Then there is a fixed splitting. In fixed splitting, what happens is, for example, this is the heart, this is the right atrium and this is the left atrium, and this is an atrial septal defect is there. So heart, the right sided pressures are more, so blood will move from right side to left side. So constantly blood is being pulled into the right atrium, and the right atrium and the right ventricle volumes are increased. So volumes are increased. It will delay the opening of the pulmonic valve. So the pulmonic valve will open a little later than the aortic valve. But here the important thing is that this opening is constant. It does not matter whether it is the inspiratory phase or the expiratory phase, the defect is there, and as long as the defect is there, the opening of the pulmonic valve will be delayed because the right side of the heart is overloaded with blood. So there is a which splitting? Fixed splitting. It happens both in inspiration and expiration. So if we combine these two occurs because the right sided heart delays. So the blood from the right sided heart delays. And then there is a paradoxical splitting. What is paradoxical splitting? it is very important. Normally what happens is that the second heart sound has two components, A2 and P2. A2 occurs, the aortic valve closes before the pulmonic. But here what happens is, for example, there is a condition in which these are the four chambers of the heart. So the left ventricle, here arises the aorta. The aortic valve here is stenosed. When the aortic valve here is stenosed, so the left ventricle, when it tries to contract, and here is a pulmonic valve from the right ventricle, and the right and the left ventricle, when they tries to contract, the right ventricle is able to pump the blood through this pulmonic valve, but the left ventricle has to take extra time for this stenosed valve to open because this is stiff. So what will happen? This A2 will be delayed. The aortic component will be delayed. So normally the P2 will happen because the pulmonic valve is able to open, and the A2 will happen after that. So that normal configuration, which was A2 P2, is changed into P2 A2. But remember what was happening during inspiration. There was a normal splitting of the A2 P2, that the P2 was happening a little late. See here, the P2 was happening a little late because of the increased venous return. So during the it is normally happening late, the P2. So it happens so late that it almost coincide with the late A2 due to stiffened valve. So we cannot differentiate a split during inspiratory phase as we were able to differentiate during physiological splitting. But during expiration, no split occurs normally. But due to aortic stenosis, the valve is stenosed, it is opening a little late. So that's why it is happening late, while the pulmonic sound is happening at its normal time. That's why the splitting is reversed to the expiratory phase rather than the inspiratory phase. That's why it is known as the paradoxical split, that normally we were expecting a split during inspiratory phase, but due to stenosed valve, the split is happening in the expiratory phase, and even in the inspiratory phase, but due to the pulmonic valve is also opening late in the inspiratory phase normally. So that coincides with the A2, so we cannot appreciate that split in the inspiratory and only can appreciate in the expiratory. That's why it is known as paradoxical splitting. Now we will discuss the heart murmurs in the next video because the video will be too longer then. So we have two types of myocardial tissues in the heart. One is the pacemaker action potential, and the other one is a cardiac action potential. So there are two types of cells in the heart. One is able to generate an action potential, and then there is a myocardium which has the ability just to contract but not to become a pacemaker. So we just divide the pacemaker action of the SA node and the AV node here. We studied it in the pacemaker action potential, and we studied the rest of the cardiac myocytes like the atria, the ventricles, in the myocardial action potential. So how the action potential is generated in the cardiac myocardium? There are four phases. The phase 0, the cardiac myocytes are at a resting membrane potential of minus 85 millivolt. So when they are at minus 58 millivolt, what happens is that the phase 0 occurs. Phase 0 means that there is a rapid upstroke and depolarization. So the voltage gated sodium channel opens, and the voltage gated sodium channel opens. So rapid influx of sodium occurs that changes the cardiac resting membrane potential from minus 85, and then it decreases until it reaches 0, and it reaches a positive action potential. When it reaches the positive action potential, it reaches phase 1, and that phase 1 is known as initial repolarization. That is caused by the inactivation of the that is caused by the inactivation of that fast channel which were open in the phase 1. They now become closed, and what happens is that the potassium efflux occurs. The potassium efflux occurs, that decreases that positive potential a little towards the zero line. So then the phase 2 happens. The phase 2 is the very important, is known as plateau phase. That happens due to influx of calcium and efflux of potassium. I'll explain it on a separate page. This is minus 85 millivolt, the normal resting membrane potential of the cardiac myocytes. Then happens the phase 0. The phase 0 is called the rapid upstroke phase. The rapid upstroke phase, that is caused by the sodium influx. Sodium comes into the cell, and that increases the resting membrane potential from 0 to a little positive 1. And then the potassium efflux occurs, that is known as phase 1, and it decreases the resting membrane potential a little lower, but it then again the next phase start is known as phase 2. It is known as the plateau phase, in which calcium influx occurs and potassium efflux occurs. These two are counterbalanced. That's why the line is isoelectric. And then it causes the phase 3. In the phase 3 there is efflux of potassium. So the massive potassium efflux, it reduces the resting membrane potential again here. And then the repolarization, there is a refractory phase. And the refractory phase, so it occurs due to potassium efflux, repolarization, and then again it repolarizes. So there is a phase known as absolute refractory period. Absolute refractory period is a phase in which you are not able to excite the cardiac myocyte with another stimulus because it is already contracting. Then there is a relative this phase is a relative refractory period, in which if you give a very strong stimulus, then you can excite it. So these are the two phases. The cardiac myocyte's action potential mainly depends on the calcium. The calcium ion is very important, and it is known as calcium dependent calcium induced calcium release, because this calcium is important for the release of sarcoplasmic reticulum calcium, and which eventually results in cardiac contractility. So all of this happens in the atria, the ventricles, except the SI node and the AV node. All the cardiac action potential is exactly like this graph. Now if we look at the second graph, it happens in the SI node and the AV node, but the key difference is this, that the phase 1 and phase 2 is missing here. And another difference is that here the resting membrane potential was too much negative, minus 85, but here it is minus 65 millivolt. So there are a type of channels known as funny channels, or funny current. So slowly it has an ability known as automaticity. The automaticity means that there is a little funny current all the time flowing through this SI node and AV node. It means that there is a little trickling of the ion inside the cell, and that slowly it takes that action potential up towards the positive side, and then that rapid threshold occurs. So in the phase 0 there is upstroke, and it occurs due to voltage gated calcium opening of the calcium channels. And in SI node and the AV node, the sodium channels are inactivated because of the less negative potential. Here they were activated, and here they are inactivated due to less negative potential, and it results in a slow uptake. And this is followed by the phase 3, the repolarization. So there are just two important phases, the depolarization and again the repolarization, and then the funny current. And this funny current happens on its own because the channels are leaky, and it is responsible for the automaticity of the SI and the AV node. So slow depolarization due to funny current happens due to slow mixed sodium and potassium in inward outward current. Now this phase 4, it determines the heart rate is determined by this phase. If the heart rate is increased, then the phase 4 duration is decreased. Similarly, the PR interval is decreased, and the heart beats faster. So it happens during sympathetic stimulation. Now if we look at the electrocardiogram, so the conduction pathway of the heart, it starts from the SA node. It is located in, then it travels towards, SA node is located here, and it travels towards the atria, and then the AV node delays the current, and then it travels to the right and the left bundle branch, and from here it divides over into the whole myocardium. The bundle branch blocks into the left one, is divided into left anterior and posterior fascicles. The SA node is located at the junction of the right atrium and superior vena cava, and it acts as the pacemaker of the heart. The AV node, it is located at the posterior inferior part of the interatrial septum, and it is supplied by the right coronary artery, and 10 millisecond delay occurs here. The cardiac myocytes, the speed of conduction velocity is very important. It is maximum at the his Purkinje, and then the atria, then the ventricles, and it is least at the AV node. That's why AV node delays the current. So the P wave, it shows the atrial depolarization. We explained it in the previous slides. The PR interval, it shows the time from the atrial depolarization to the start of ventricular depolarization, and the QRS complex shows the ventricular depolarization. You have to remember the time period as well, that normally the P wave is 2 to 3 small boxes. The PPR interval is 120 to 200 milliseconds. So you have to remember the time interval as well, that one small lock is 0.04 milliseconds, and the QT interval represents the ventricular depolarization, and the T wave shows the ventricular repolarization. There is a point known as J point, which is at the junction of the QRS and the ST segment. Then there is another way where there are some diseases related to this. For example, the first degree heart block. In the first degree heart block, the PR interval is increased, nothing more, just PR interval is increased. In the second heart block, it has two types: type 1, also known as Vanke back, and type 2. In the type 1, the PR interval progressively prolongs until a QRS complex is dropped, and in the type 2, what happens is that there is no progressive prolongation of the PR interval. Just abruptly the QRS complex drops. So, and then there is a third, in which there is AV dissociation. The atria beats at its own pace and the ventricle beats at its own pace, and there is no rhythm in between the two. So we need pacemaker for type 3 and second degree type 2. We need pacemaker for these two. And then there is a disease which is known as Wolff-Parkinson-White disease or syndrome, in which there is a PR interval is reduced, and there is a delta wave like this. There is P. So there is a delta wave, that the rapid upstroke in the QRS complex happens, and this is because of an accessory pathway known as the bundle of Kent. So it was all related to the ECG. If you want a detailed video on this, I can make that. Comment down below. We will discuss the topics that are left in a separate video along with the heart murmurs. Thank you.